Join top presenters from RSNA at the upcoming Spotlight course, Expert Insights on Emergency and Abdominopelvic Imaging, held in Istanbul, Turkey, on June 28th and 29th. Build your image interpretation skills and explore the latest advancements in body imaging and emergency radiology with this in-person course featuring interactive panels, small group discussions, demonstrations, and networking opportunities. Learn more and register at rsna.org/spotlight.
Hi, welcome to the RSNA Radiographics podcast. I'm your host, Dr. Lily Wang, an associate professor and neuroradiologist at the University of Cincinnati. Today, the article we're going to discuss is titled Practical Approach to Orbital Lesions by Anatomic Compartments. This is by Dr. Guilherme Gotti Neves and colleagues from Brazil. This article provides a comprehensive and practical review of orbital pathology based on location. The orbit can be divided into intraconal, conal, and extraconal compartments. Additionally, the optic nerve sheath complex and necromal apparatus can be partitioned into separate compartments due to their unique function and pathologic features. Let's start with the optic nerve sheath complex. It is formed by the optic nerve and its dural and leptomeningeal coverings, which extend from the intracranial meninges to the globe. It is filled with CSF. The first entity is optic neuritis. It is an inflammatory optic neuropathy. Patients usually present with acute or subacute vision loss, often accompanied by periocular pain and painful eye movements. Most cases are related to demyelinating disease like multiple sclerosis. In typical MS-related optic neuritis, it is usually unilateral, affecting the anterior intraorbital segment of the optic nerve. On MRI, you will see contrast enhancement, T2 hyperintensity, and sometimes even diffusion restriction. However, if it's bilateral, if more than 50% of the nerve is involved, or if you see posterior intraorbital or chiasm involvement, start thinking about alternative diagnoses. These include neuromyelitis optica, MOG antibody disease, or even autoimmune and infectious diseases like sarcoidosis or herpes zoster. Next, let's talk about ischemic optic neuropathy. It is an acute vascular disease. The optic nerve is primarily supplied by the ophthalmic artery branching off the internal carotid artery. On MRI, look for T2 hyperintensity, reduced contrast enhancement, and restricted diffusion. In anterior ischemic optic neuropathy, you might see the famous bright spot sign due to ischemic edema. The sensitivity of detecting diffusion restriction is highest within 5 days of symptom onset. Early diagnosis is crucial because if it is due to giant cell arteritis, it can benefit from urgent steroid treatment to prevent permanent vision loss. Next, let's talk about optic nerve gliomas. These are the most common primary tumors of the optic nerve. Typically low-grade astrocytomas found in children. There's a strong association with neurofibromatosis type 1. Bilateral optic nerve gliomas is considered pathognomonic for NF1. On the other hand, adults can present with more aggressive high-grade astrocytomas. On MRI, an optic nerve glioma generally appears as an enlargement of the optic nerve. On T1, the signal is typically iso-intense. On T2, it is iso to hyper-intense compared to the contralateral nerve. Contrast enhancement is minimally present at all. The tumor is indistinguishable from the nerve itself. In patients with NF1, we often see increased tortuosity of the nerve and optic nerve enlargement. A peripheral rim of T2 hyperintensity is frequently noted, reflecting an expanded dural sheath and myxomatous tissue. In sporadic cases, patients without NF1, the gliomas tend to look more mass-like and sometimes with cystic components. Next entity is optic nerve sheath meningioma. It is a common benign tumor. The neoplasm arises from meningoendothelial cells of the meninges that surround the optic nerve. Primary optic nerve sheath meningioma often involves the intraorbital and intracanalicular segments of the nerve. Patients typically present with unilateral painless and progressive vision loss. Fundoscopy often reveals optic nerve atrophy. On imaging, you typically see thickening of the optic nerve. This thickening is usually tubular but can appear globular or fusiform. Intratumoral calcification is common. There is homogeneous enhancement of the tumor, and on axial or sagittal imaging, the enhancing tumor can wrap around the optic nerve, creating the famous tram track sign. The next entity is optic perineuritis. When it is caused by idiopathic orbital inflammatory disease, it is called primary optic perineuritis. But it can also occur secondarily to autoimmune or infectious disease, such as vasculitis and sarcoidosis. Clinically, it can look very similar to optic neuritis. Perineuritis progresses more slowly, typically more than 2 weeks, and there is no spontaneous improvement. It tends to affect older patients compared to classic optic neuritis. On imaging, the hallmark feature is linear enhancement of the optic nerve sheath, often with infiltration of the intraconal fat, but spares the optic nerve itself. Now let's move to the intraconal space. The intraconal space contains fat, orbital vessels, and cranial nerves, primarily motor nerves responsible for ocular motility. Pathologically, vascular lesions are most commonly observed within this space. Orbital vascular lesions can be divided into vascular tumors and malformations. Tumors show proliferating endothelium, while malformations arise from developmental errors in angiogenesis. Malformations can involve arterial, venous, or lymphatic vessels, and sometimes a combination. Let's first talk about cavernous venous malformations. This used to be called cavernous hemangiomas. They are the most common benign orbital masses in adults. The cavernous venous malformations are usually located in the lateral retroorbital intraconal space, but can occasionally be in the orbital apex or extraconal space. They are more common in middle-aged women, and patients typically notice a slow progressive painless proptosis. On CT, cavernous venous malformation appear as well-defined soft tissue masses, sometimes with phlebolith. They may be adjacent bony remodeling. On MRI, these are typically iso on T1 and hyper on T2. They may be internal septations, which may appear as dark lines on T2. Next, let's talk about venous malformations, or orbital varices. These are abnormal venous networks, and their standout feature is distension with increased venous pressure, such as during Valsalva. Clinically, the patients can have reversible proptosis. Venous malformations can suddenly worsen if there's thrombosis or hemorrhage, causing painful swelling and even bruising. On imaging, they are usually in the intraconal space and connect with the superior or inferior ophthalmic veins. Look for lesions that distend during Valsalva, containing phleboliths, and show evident enhancement. They are hypo to iso on T1 on MRI and hyper on T2. Areas of bleeding can appear bright on T1. Then there's the lymphatic malformations. These are made of anomalous lymphatic vessels, typically cystic spaces filled with fluid. They're usually diagnosed in early childhood. When an lymphatic malformation suddenly enlarges, often due to bleeding or infection, patients experience painful proptosis, restricted eye movement, and even vision loss. On MRI, lymphatic malformations are transspecial with cysts. They may be macrocysts or microcysts. A classic sign is the fluid levels from bleeding inside these cysts. Lymphatic malformations don't usually enhance, so if you see enhancement, it's likely due to a venal lymphatic malformation. Next, let's consider orbital metastases. These are not very common, And the most common primary tumors include breast, melanoma, prostate, and lung cancer. Patients present with proptosis, orbital swelling, pain, and diplopia. You can have enophthalmos is paradoxical due to sclerotic or serous tumors such as breast and gastrointestinal metastases. The fat contracts and causes negative mass effect. Let's move to the conal space. The conal space is delineated by the extraocular muscles which converge at the orbital apex. The four recti muscles form a tendinous ring, the annulus of Zinc, surrounding the optic canal containing the optic nerve and ophthalmic artery. Let's start with thyroid eye disease. Thyroid eye disease is an autoimmune disorder affecting the tissues around the eye. It's most commonly associated with Graves' and hyperthyroidism, but can also appear in patients with hypothyroidism or even normal thyroid function due to Hashimoto disease. Clinically, thyroid eye disease tends to be bilateral and symmetric. It causes restricted eye movement leading to double vision and strabismus. Common symptoms include eyelid retraction and proptosis. Active disease can cause signs like orbital pain, swelling, and redness. On imaging, it causes the Coca-Cola bottle sign with muscle belly enlargement or sparing of the tendinous insertions. You can see increased orbital fat volume, lacrimal gland enlargement, and T2 hyperintensity. These suggest active inflammation. A commonly asked board question is the order of muscle involvement in thyroid eye disease. So remember, I and slow. Inferior rectus, medial rectus, superior rectus, lateral rectus, and obliques. Now, severe swelling at the orbital apex can cause compression leading to vision loss. Therefore, they may be treated with decompression. Next, we're going to talk about idiopathic orbital inflammation. This is an inflammatory condition of unknown cause that can affect many parts of the orbit, but extraocular muscle involvement or myositis is particularly common. Patients often present with acute or subacute eye pain, swelling, redness, proptosis, and painful eye movements. It is usually unilateral and responds well to corticosteroids. Imaging typically shows homogeneous muscle enlargement, including the tendinous insertions, creating a tubular muscle shape. You may also see fat stranding around the affected muscles and contrast enhancement. On T2-weighted MRI, hyperintense areas suggest active inflammation, while hypointense areas suggest fibrosis. Next, let's talk about immunoglobulin G4-related orbital disease, or IgG4 ROD. It's part of the multi-system immune-mediated condition marked by tissue infiltration with IgG-positive plasma cells and fibrosis. In the orbit, it often involves the lacrimal gland and extraocular muscles. Patients typically have painless swelling, proptosis, restricted eye motion, and diplopia. They may have a chronic or subacute course. Imaging shows homogeneous muscle enlargement with tendinous sparing, adjacent fat inflammation, and contrast enhancement. MRI often shows intermediate to low T2 signal intensity from fibrosis or cellularity, though sometimes you can have patchy T2 signal that can suggest active inflammation. The lateral rectus muscle is most commonly involved. So if you see lacrimal gland involvement, cranial nerve involvement, and paranasal sinus involvement, these can also point towards IgG4 disease. Neoplastic involvement of the extraocular muscles are less common. Primary tumors that originate within the extraocular muscles like metastases or lymphomas are relatively uncommon. They typically present with proptosis, diplopia, and ocular motility disturbance. Pain is typically absent in lymphoma but can be present in metastatic disease. Lymphoma usually presents with unilateral involvement, and you will see fusiform-shaped muscle enlargement, which may involve the tendinous insertions. Look for diffuse homogeneous enhancement and low ADC values on diffusion. In contrast, mass typically either appear as a focal mass within the muscle or as diffuse infiltration. These often have irregular margins and show enhancement. There may be restricted diffusion or unusual enhancement patterns. Let's move to the extracorneal space. Infectious disease is the most frequently presented primary orbital pathology in the extracorneal space. Bacterial infections are the most common, but you can also get fungal infections in the immunocompromised patients. Next, we'll talk about the extracorneal space. In this space, infection is most common, typically bacterial infection, but in immunocompromised patients, you can get invasive fungal infection. It's important to distinguish between preseptal and postseptal infection on imaging. Classically, the patients present with pain and swelling and redness. But if you see proptosis, vision change, or ophthalmoplegia, think of postseptal involvement. Infantile hemangiomas are benign vascular tumors. These are pretty common in infancy. Typically, the superficial ones don't require imaging. On MRI, early lesions are iso on T1, hyper on T2, and show strong homogeneous enhancement. They may have flow voids. Next, we talk about rhabdomyosarcoma. This is the most common mesenchymal tumor in children, and they typically present with rapid progressive unilateral proptosis and swelling. Imaging shows homogeneous lesion with diffuse enhancement. Bone erosion is common. If there's involvement of orbital bones or optic nerves, the prognosis is worse. The next entity is nerve sheath tumors. Schwannomas are benign cells arising from Schwann cells, often involving branches of ophthalmic nerve. It's difficult to distinguish from neurofibromas, but the history may help, like NF1 or NF2. On T2-weighted imaging, neurofibromas can show a target sign with a hyperintense rim and central hypointensity. The next compartment is the lacrimal apparatus, which includes the lacrimal glands, lacrimal sacs, and the ducts. Pleomorphic adenomas are common benign tumors that can involve the lacrimal gland. Patients present with a painless unilateral mass and sometimes proptosis. On imaging, these tumors are well circumscribed round oval lesions, which enhance. This contrasts the malignant epithelial tumors. Typically, these are adenoid cystic carcinomas, carcinoma X pleomorphic adenomas, and adenocarcinomas. These tumors can be firm, painful, and rapidly growing with proptosis. They can have perineural spread, causing orbital pain or paresthesia. If you see bony erosion, poorly defined margins, and invasive patterns, this is concerning for these malignant tumors. On MRI, they typically hypointense on T1, intermediate to hyperintense on T1, T2, and often show heterogeneous enhancement with restricted diffusion. Now let's talk about the globe. The globe has 3 major layers. The outer layer is the sclera and cornea. The uveal tract includes iris, ciliary body, and choroid. The internal neural layer is the retina. The lens divides the globe into anterior and posterior segments. Let's start with the anterior segment. Uveitis refers to inflammation of the uveal tract. You can have anterior or posterior uveitis. MRI shows thickening and enhancement of the uveal tract, subretinal effusions, and abnormal signal in the humerus. Now, endophthalmitis is an emergency. This is an infection involving the vitreous or aqueous humor, usually after trauma surgery or through hematogenous spread. Imaging features include periocular inflammation, uveoscleral layer thickening and enhancement, and increased aqueous humor signal on flare sequences. TWI may show restricted diffusion in parallel collections. Now let's move on to the lens. The lens usually sit snugly in the hyaloid fossa, anchored by the zonular ligaments to the ciliary bodies. You can have dislocation or called ectopia lentis. This is usually typically due to trauma or can be due to systemic conditions such as Marfan syndrome or homocystinuria. Next, we'll talk about posterior segment pathology. Retinoblastoma is the most common intraocular malignancy in children. MRI typically shows T2 hypointensity. On T1, it can be slightly hyperintense relative to the vitreous. Intralesional calcification is common in retinoblastoma. Next, we'll talk about uveal melanomas, which is the most common primary intraocular malignancy in adults. Choroidal melanoma is the most common type. It carries a high risk of hematogenous metastases. On MRI, it is T1 hyperintense, T2 hypointense. Look for the mushroom shape if the tumor breaches the Bruch membrane, and beware that large tumors can cause retinal detachment. Congratulations! We have completed our tour of the orbit through different compartments looking at different pathology. Thank you so much for tuning in into Radiographics Podcast. This is Dr. Lily Wang. Don't forget to subscribe for insights into imaging. Please take a look at the images in this article on the Radiographics website. We'll see you next time. Bye.